Welcome to the Princeton Spine and Joint Center podcast. My name is Dr. Marco Funiciello, and I am the co-director of the Interventional Pain Program here at Princeton Spine and Joint. I had a fantastic conversation today with Dr. Sandro LaRocca. Sandro is the director and founder of the New Jersey Neck and Back Institute. He's a fellowship-trained spinal surgeon, and he's board certified by the American Board of Orthopaedic Surgery. Today we had a fantastic conversation about cervical spondylotic myelopathy. We talked about the symptoms, the causes, and the surgical approach to treatment. Enjoy. Sandro, thanks for joining us today, and we're covering the topic of cervical myelopathy. So first question I have for you, what is a cervical myelopathy?
I think it may be helpful in order to describe what a cervical myelopathy is to describe the individual terms. A myelopathy, to start with, it's helpful to understand some basic anatomy where you have the nervous system, which is composed of the central nervous system consisting of the brain and the spinal cord, and the peripheral nervous system, which goes out to the remainder of the body. The brain, of course, processes all information and sends signals to activate the organs, the musculoskeletal structures of the body. The conduit between the brain and the peripheral nervous system is, of course, the spinal cord. Now, the nervous system is composed of nerve cells or neurons. These neurons have a layer or a coating analogous to the insulation, the rubber insulation on an electrical wire. If there's a break in that insulation, there's dysfunction of the electrical wire. Similarly, the neuron is coated with a substance called myelin, hence the term myelopathy if there's a problem with the myelin. When there's damage or injury to the myelin, there's a dysfunction of the nerve cell. The normal signal transmission is disrupted, and hence you ultimately get nerve dysfunction.
Now, is it always just the myelin that's damaged, or can the wire itself, can the axons get damaged in a cervical myelopathy?
It can, and there's varying degrees of this injury. You may have just injury or compression of these substances or compression of the nerve, but you can ultimately have death of the nerve cell itself or the wire in this analogy.
Right. When we talk about cervical myelopathy, what exactly is happening in the spinal cord?
Well, let's talk first what the process is. The spine, like any other musculoskeletal structure, undergoes wear and tear, degeneration over time. What happens is the spine is composed of the vertebral bodies of the bones separated by the discs. And in the back of the spine, you have the little joints called the facet joints or the psychopophyseal joints. They act to stabilize the spine, and one of their major functions is to protect and carry the neurologic structures, specifically the spinal cord and the peripheral nerves. What happens in the course of degeneration, the discs start to lose over time their structural integrity. They start to flatten out and bulge out. This produces some bone spurring at the vertebral bodies. Then you start to have arthritis in the little joints in the back of the spine, which start to, again, produce bone spurs. The ligaments within the spine start to thicken, and sometimes they buckle in the course of this. But all of this adds to this process of stenosis, or narrowing around the neurologic structures. It's compressing the spinal cord. The compression can result in injury from direct mechanical compression, but also there's a component of blood flow. With the compression, you also cause ischemia or a lack of blood flow to the cord, which can further add to injury to the neurologic structures.
Right. Okay, so it sounds like basically over time you're getting less and less space for a cord that needs space and needs blood flow, and it compromises the cord. It causes compression and then swelling.
That's correct.
swelling of the cord itself. And does this swelling then further contribute to the narrowed space? Does it actually start to take up more space now, more space than it has?
It actually does. Now you have this inflammatory process, which, as we've all seen, when you have inflammation of an injury, you get swelling. Right. So that further adds to the stenosis, the stenotic process, which now further adds to injury and progression.
So with a cervical myelopathy, we talk cervical, just referring to the cervical spine. Can a myelopathy happen in any part of the human spine, whether it's the neck, the mid-back, or the lower back? Or is do we call it cervical myelopathy because it's most common in the cervical spine?
A myelopathy can happen anywhere in the nervous system because there's nerve cells throughout, in the brain or even in the peripheral nerves. But when we're speaking about the spinal cord, yes, it is most common in the cervical spine. The spinal cord travels down to the mid-back or the thoracic spine, but because of the motion that occurs in the neck, and because of the causes of a cervical spondylotic myelopathy due to degenerative changes, there's more stress in the neck, more motion, which causes breakdown of the spine and subsequent stenosis that may result in the myelopathy.
What are some of the symptoms that someone might experience if they have a cervical myelopathy?
Patients generally present with a number of symptoms or signs. They can occur independently in isolation or with a combination of these symptoms or signs. Many times they'll have neck pain. The neck pain may radiate into the shoulders or into the upper extremities. It's many times associated with numbness in the hands. They may describe a sensation of losing coordination. They may feel clumsy with their hands. They may say they have difficulty typing on a keyboard, buttoning their shirt or fixing the clasp of a necklace. They're having increasing difficulties with that. It can also affect the lower extremities where they may start to feel a loss of balance or coordination with walking. Their walking pattern changes. They feel it change. They feel like they're going to fall over. In more severe cases, they may have actually some bladder dysfunction where they're having difficulty controlling their bladder, if not frank incontinence in the most severe cases.
So I see patients every day who have neck pain, back pain, pain radiating into their arms and limbs. Often they have not had an MRI yet, and I order an MRI, and I see that there are signs of cervical myelopathy in some cases where they might have some cord swelling. Whenever I see those cases, I do like to get a surgeon's opinion because that means it's a bit more far gone. It's a bit more of a serious case, especially if they have any neurologic symptoms. So from a patient's perspective, no one wants to get surgery for their spine. But from a patient's perspective, when do you start thinking that this person needs surgery versus someone else who may not need surgery?
I think in order to answer that, it's important to understand sort of the natural history or what happens with a myelopathy, with a cervical spondylotic myelopathy in particular. The natural history dictates that it's a progressive disease. The neurologic dysfunction is progressive. In most cases, it progresses in a stepwise fashion.
Progressive meaning just going to keep getting worse over time naturally if you don't intervene. That's what you mean, correct?
That's correct. Yeah. And the time may be a couple weeks or it may be years. Right. Okay, but this stepwise progression. In this stepwise progression, you have some deterioration that may last for a short time. Then you have stabilization, again, for a time that's unpredictable. And then at some point later on, you may get further deterioration and you stabilize at that level. Right. And this progressive deterioration may ultimately become severe to the point where the patient becomes unable to walk, or as I stated, have good control of their bowel and bladder. In terms of determining when a patient is surgical, you have to look at the patient as an individual. Generally speaking, The indications for surgery are in patients that are moderately to severely affected. If you have a patient with findings of cord compression due to stenosis in the cervical spine, they may be fine. They may not exhibit any of the signs or symptoms of myelopathy. Depending on the severity of the cord compression, I may choose to observe them. Okay. Now, understand that the whole decision-making process is an informed decision-making process with the patient and the physician. I counsel them on the pathology, what the problem is, and the potential risks of proceeding with surgery and the potential risk of not proceeding with surgery. But back to the patient who has mild disease, we typically observe those. Right. Okay, when you start to have increasing signs and symptoms of myelopathy, increasing dysfunction, that's when I start to be more inclined to recommend surgery. Now, there's also the subset of the patients who have cord compression on their MRI, and these are the patients who have severe cord compression, but they may be relatively mild in their presentation.
Right.
But those are the patients I may say, look, you're not affected right now, and we can observe this, but understand that with any small a fall or a trauma, even a minor one, where you hit your head or may have hyperextension of the head acutely, that may cause cord injury or something called a central cord syndrome, right, which in and of itself is a problem. Okay, it can result in paralysis and dysfunction.
How big is that risk that they can simply take a slip and fall, hit their head, and have spinal cord damage? How real is that risk?
It's difficult to quantify that.
Right.
It's not something that we've been able to study.
Right.
For obvious reasons.
Sure.
But the possibility is there.
Gotcha. So what type of, let's say you decide to move forward with surgery, what type of surgery generally is required for cervical myelopathy with signs and symptoms or pretty severe compression with maybe some cord swelling? What type of surgery would be involved?
Well, that's an individualized plan. You develop a surgical plan on an individual basis. There's many factors to consider. First of all, I look at the health of the patient, the age of the patient, how much surgery can they tolerate. The surgery that's typically involved is pretty intensive and demanding, from a technical standpoint, but also from a medical standpoint. It can put significant stress on the patient. It can put significant stress on the patient. Yeah. And that's always the first consideration. Right. Then we have to consider what our objectives are. We have to consider where the cord compression is, where the damage is occurring, how many levels are involved. Is the compression of the cord more towards the front of the cord or to the back of the cord? I also have to consider what is the general alignment of the spine, because the alignment dictates what I can do from the front, what I can do, or what I should do from the front, or what I should do from the back, or both. So those are factors that I generally consider. Where is the compression? Is the compression just at the disc level? Is it one level where the disc is protruding into the cord, or is it multiple levels? Or is there compression behind the bones of the spine or the vertebrae, in which case I may have to remove a vertebrae or part of it to adequately decompress. And the goal is to completely decompress the spinal cord to eliminate any source of further injury.
One question I get from my patients is, Doc, can I get one of those small surgeries, those microsurgeries, a microdiscectomy, for example, for a cervical myelopathy? What would you say to a patient who asks that question?
If it is a single level disc herniation, compressing the spinal cord, in fact, the standard anterior cervical discectomy and fusion is a minimally invasive procedure. Fundamentally, that's what it is. Anything other than that, it's not. You cannot do it. I would be concerned about getting an adequate decompression and reconstruction with a minimally invasive approach.
They might have to go back for surgery later because
That's correct.
Not enough of the spinal cord was decompressed, basically.
Generally speaking, these are not minimally invasive procedures because in most cases, the degenerative process which leads to the stenosis leads to multi-level compression of the cord. And frequently you may find other levels which are based on your preoperative imaging, you're able to find some instability which at other levels which may also be contributing to the damage occurring, which also need to be addressed. Typically what the main goal is decompression of the cord. Okay, but in the course of decompressing the cord, you destabilize the spine. So the next component of the surgery is to stabilize the spine, and that's done through reconstruction and fusion. And that can be done, as I previously noted, depending on where the pathology is or where the problem is. It can be done from the back or from the front, or in many cases, a combined front-back procedure is necessary.
What can someone expect in terms of recovery time?
Well, in terms of recovery, I should say that the goal of surgery is to arrest the progression of the disease. That is a realistic and reasonable goal. They're finding more and more, and some of my personal experience is if you get to it early enough, there is a significant amount of recovery.
Recovery, right.
And in terms of what is the recovery time, that depends on the patient, the severity of the disease, the type of surgery, the extent of surgery that was necessary. So that's a very difficult question to answer on a general basis.
But basically, it sounds like you're trying to stop things from progressing further. So there is a chance that whatever function they have prior to surgery, that's the same function they're going to have when they get out, perhaps with less, maybe with less pain in the limbs, for example, or less symptoms. But they may not recover further, but you'll stop the progression, the downward spiral of that disease. And perhaps there will be some recovery.
That's exactly correct.
Okay. All right. And do they do physical therapy? What are their activity limitations, both in that immediate, the first few weeks, months afterwards, and then eventually, how active of a lifestyle can they get back into? Can they go out and play sports? I'm sure this is very individual, but what's been your experience with people having the surgery and going out and being active again?
That is, like you said, it's a very individual outcome. And generally speaking, as we noted, the goal is to arrest the progression of the disease. So they're likely to continue with some dysfunction at whatever level they went into the surgery with. But we can perhaps improve that. Depending on the nature of the surgery, sometimes there will be some immobilization in a collar, especially with the longer, larger, more complex reconstructions. You have to make sure that a fusion is taking place, it's stable and healing. But even then, when they have to wear a cervical collar or an orthosis, I will start them early in physical therapy, not just to help them recover from the surgery, but also to help them start recovering from maybe the long duration of disability they've had prior to
they're deconditioned.
They're deconditioned,
yeah, absolutely.
And maybe they can work with them on some of their deficits to help improve them or help them compensate for those.
Right.
So it's a process. And again, it depends on the severity of the disease and how badly it affected each patient. So the time issue, generally when you're talking about a fusion, getting the bone to heal to bone to achieve ultimate stability, you're talking about 2 to 3 months. Right. Okay. In most of those cases, particularly in the longer, more complex reconstructions, I will keep them in a collar for a fair amount of time. So then when you start to realize that they're healing, you're able to confidently say that they're healing. You start mobilizing them there, and they're pretty stiff in most cases, and that just takes some time to overcome. But the goal is to return them at least to their previous level of function. And like I said, in many cases, you can do better than that. Now, playing sports after a complex cervical reconstruction
probably depends on the sport.
Depends on the sport.
Hiking is one thing.
Hiking, that's correct.
But perhaps playing anything which may involve contact, I would imagine.
Oh no, that's absolute no.
What about something like tennis, where there shouldn't be contact, but there could be a trip and fall, and it's much more. There's cutting involved. What about a sport like that? And again, it probably depends on the type of surgery and how severe the symptoms were, and all those things. But
somebody that has 1 or 2 level disease, who has had a 1 or 2 level discectomy and fusion from the front, absolutely, they can get back to that. That is not a problem, as long as their neurologic function allows it. But from the standpoint of the stability of the reconstruction and the healing of the surgery, it's typically not a problem.
I see. And do you often see someone has cervical myelopathy? Do they have complicating factors? Maybe another area of their spine that's also compressed. And what do you do in those cases where they may have some gait instability, but they also have a large disc herniation in their lumbar spine? And how does one pull apart what's coming from what, and where do you start with surgery?
Well, that's a good question, because fundamentally, the cervical spondylotic myelopathy, spondylosis, is a term that relates to degeneration of the spine.
Yeah, I mean, wear and tear in the body over time.
That's right. And degeneration occurs in every part of the spine, and most significantly in the neck and the low back. Right. So if you have problems in the neck leading to this stenosis or compression of the neurologic structures there, in many cases you have concurrent problems in the lumbar spine.
Right.
Okay, so yes, you're correct. If somebody comes in with difficulty walking, many times, they'll be sent by their primary care physician with an MRI of the lumbar spine, which shows maybe a herniation or some stenosis there, which could certainly be causing problems. But when I talk to the patient and do a good examination, I realize maybe they have some abnormal reflexes in their upper extremities, or they have hyperreflexia or increased reflexes in the lower extremities, which is not consistent with a lumbar spinal problem. Right. I could say, wait a second, something else is going on. And at that point, I start looking into a problem higher up, specifically in the neck or even in the mid-back. Right. So we do see that. And it becomes important to be able to sort out what needs to be treated, where the problem is, it's a triage process. Technically, if there's a problem in both areas causing neurologic dysfunction, I tend to address the spinal cord issues primarily, and then the lower, in the lumbar spine, it's a different issue. With the cervical spine and the neck, you have the spinal cord, and that's more important than the more peripheral nerves in the setting of this situation. Right.
And I bring that up specifically because, as you had said, there's a chronic degenerative change that occurs, unfortunately, in our spines, and we do develop arthritis, worsening stenosis, narrowing in the spine. When I see patients with cervical myelopathy, I always get a surgical opinion, because it's important, because it's degenerative, it's chronically degenerative, and it will be progressive. So, but if they also have a concurrent problem in their lumbar spine, there are some tricks and tools that I often use, electrodiagnostic testing, to see if that disc herniation is actually causing damage to a lumbar, to a lower back nerve that's causing symptoms into their leg. And then I can concurrently do injections for the lower back while I send this patient to a spinal surgeon. And if their back and legs get better, but their other symptoms don't, then we can also, that helps us to differentiate where the problem's coming from in those cases with patients who have more than one problem. So that's been a helpful tool for me.
Sure.
But absolutely getting a surgeon on board when I see that cord swelling, it's something I don't like to see, and it's something usually my needles can't fix. We need to open up that space. So any other caveats, any other things that you've seen with cervical myelopathy? I think we covered a good section of what we wanted to discuss today, just having patients understand exactly what a cervical myelopathy is, the signs and symptoms, treatments for it, and recovery afterwards. Any other things we should add in?
No, I think to your point about having concurrent problems in the neck and the back. Yes, the electric diagnostic studies are an excellent tool to help. But when I talk to a patient and examine them, when you look at the neurology,
you usually know the answer just from.
At the very least, I'll say, wait a minute, something's not correlating, something's not right here, which requires further investigation, which may consist of imaging, the electrodiagnostic studies. Right. But one other thing I will say too is that as I mentioned, myelopathy can affect any part of the nervous system. So there are other entities or disease processes to consider. And common ones are things like ALS, amyotrophic lateral sclerosis, or otherwise known as Lou Gehrig's disease. MS, very common.
Absolutely.
And they can look very similar to the cervical spondylotic myelopathy. There are some essential differences, but in many of these patients who have neurologic dysfunction, I will also get a concurrent neurological evaluation to make sure, maybe there's a coexisting problem, or to make sure it's not actually something else. So I'm working as well with the neurologists to diagnose and treat this patient.
Excellent. All right. Well, Dr. LaRocca, Sandro, thanks for joining us today. It was really a pleasure having you.
Thank you for having me.
My pleasure.